So good morning. We've still got people drifting in, but I think we'll make a start. Thank you for joining us for this penultimate session of PMAC 2023. My name is Ashley McKim. I'm Director of Innovation and Improvement at BMJ, and it's a real pleasure to moderate this session. I think it's a really exciting session. The whole week at PMAC, we've been talking at a very high level, at a multilateral level, about how policy can impact and reduce the impact of healthcare and the environment. We've talked about health systems, and this session is really about how do we bring that to the front line? How do we engage more than the 800 people here? If we want to change climate change in healthcare, we have to engage the 59 million healthcare workers, not just the 800 people here at PMAC this year. So we need you to go away and empower and inspire people to be able to do that. And we've got a fantastic list of speakers here with us today, some in person, some joining remotely. And the sort of components for today's 2-hour session, we've got some fantastic speakers. We've got Shweta and we've got Fazia introducing this concept to us. We've then got a fantastic panel, and we've got some case studies of people on the ground who have actually done projects as well. We normally do a conflicts of interest declaration, but what we actually did today, we are doing a CO2 declaration. This is the CO2 emissions from the speakers who have come to be part of this panel today. And this is the equivalent. We've burned 14 tons of carbon on flights coming to Bangkok to be part of this panel. If we'd engaged the entire panel, it would be 3 times that. And that's the equivalent, just to the panel here today, of nearly 4 people in Thailand. That's the equivalent of 4 Thai local population CO2 emissions per year. So just keep that in mind as we go through the session today. We want to start off by asking you a question. And we were going to do this via Slido, but technology's worked against us. So we're going to do this the old-fashioned way of raising your hand. So before we start, I want to ask you personally, how do you feel your work or organization has a positive or negative impact on the environment? There's 3 answers to this. The first answer is that you or your organization has a positive impact on the environment. The second answer is that it's neutral. Or the third is that your organization currently is having a negative impact on the environment. Okay, got that? So anybody think answer A, is your organization having a positive impact on the environment at the minute? 1 person, 2 person, 3 person. That's it. 4. Anybody neutral? Anybody think their organization's not having a positive or negative effect on the impact? 1, 2, 3, 4, 5, 6, 7. And who feels their organization currently is having a negative impact on the environment? The majority of people in this room. Okay, let's bear that in mind. We're going to come back and talk a little bit more about that later on today. And the second bit, which I hope is more positive because you're here at PMAC today, is do you or don't you feel empowered to go back and change things in your organization to reduce the impact in the environment? So who feels that they can go back after PMAC this week and make a change in their organization to reduce the impact in the environment? Okay, and hands down, who doesn't feel they can go back and change their organization or make a difference? Anybody? 1 or 2 people at the very back. And we'll come back, we might ask you later on just for some feedback on that, because we, as I sort of mentioned at the beginning, part of this is about how do we inspire everybody in healthcare to go away and make a difference, and how do we share practical examples that make it easy for them to be able to do that as well. So we're going to kick off with our first, I hope, really inspiring speaker, and Shweta's spoken at our events before. I find her terribly inspiring. She's from Healthcare Without Harm. She's their climate and health campaigner, and she's going to help us get inspired for this session ahead. Shweta, over to you.
Thank you, and good morning, everyone. Thank you for this opportunity to start this session, and I'm going to keep it broad, and I hope my co-panelists would be able to bring it to some of the examples, specific examples that we can undertake. But just to start with, that the health of our planet is so deeply linked with the health of all its inhabitants that climate change is not just an environmental crisis, it's a public health crisis. And it threatens the very existence and well-being of the current and the future generations. And I think it's very important to recognize this fundamentally right in the beginning. And one more thing, sometimes we tend to talk about climate crisis as a crisis in the future, and that's not true. We are living in the present. The climate crisis is in the present. And severe temperatures, excessive rainfalls and floods, more frequent extreme weather events are all evidence of this. I just want to refer to a joint report presented at COP27 in Egypt by the World Meteorological Organization and the United Nations Economic and Social Commission for Asia and the Pacific. And it highlighted that in 2021 alone, at least 48.3 million people in Asia were affected by over 100 extreme weather events and natural hazards. The total economic damage from such extreme weather events was estimated to be $35.5 billion. And these events included droughts, extreme temperatures, floods, glacial lake outbursts, landslides, and so on and so forth. And the two main extreme weather events that has affected Asia primarily have been floods and droughts. And as of yesterday evening, New Zealand has declared emergency because of unprecedented rainfalls in Auckland that has already claimed 3 lives, as far as what the morning news said. This is the reality we are living in. And extreme climate events not only threaten people's health, but also healthcare's own infrastructure and capacity to respond. I live in Kerala, in India, and I was witnessing firsthand the health impacts of Kerala floods, especially on the health infrastructure. Hospitals had to shut down, shift patients, postpone critical surgeries. Many had to face structural damage that went on for months after the floods. Medicine stocks were lost, vaccine stocks were lost, and it goes on. And this is not unique to this one special episode in Kerala. We have seen examples of this across the world. Just one example to quote was the impact that Hurricane Sandy had on New York hospitals, where hospitals had to shut down because of technical and electrical failures. I feel that there is also a paradox here, and with which an opportunity arises. While the health sector plays a central role in responding to the climate crisis, the sector itself contributes to nearly 5% of net global greenhouse gas emissions and growing. And this is a very important point to remember from all of us who are part or working with the health sector. The philosophy of first do no harm should begin at the health center, and health centers should be places of healing and not places of causing more disease and destruction. Some of the main sources of emissions in the sector is from energy, transport, operational emissions, pharmaceuticals, and waste. Now, in 2021, Healthcare Without Harm released a global roadmap for healthcare decarbonization. And our assessment indicates that under business as usual scenario, healthcare's footprint will triple by 2050. And our analysis also indicated that through 7 high-impact actions, healthcare can reduce its emissions by 44 gigatons by 2050 and close in on zero emissions. These actions, and these 7 actions, are primarily powering health with 100% clean, renewable electricity, zero emissions buildings and infrastructure, zero emissions sustainable travel and transport, healthy and sustainable food to be provided in healthcare facilities, incentivizing and producing low-carbon pharmaceuticals, implementing circular healthcare and sustainable healthcare waste management, and establishing greener health system effectiveness and efficiency. There was a study published last year, or probably a little later than last year, that showed that if we continued with business as usual, 70 million more people would die of heat stress alone by the end of century. Healthcare can save 5 million lives just through these 7 actions. And the health sector can achieve decarbonization while ensuring greater health equity and climate justice between nations. I think it's now also important to highlight that the health sector is beginning to understand the impacts of its own climate footprint and the seriousness of it. And in the last couple of years, we have seen a tremendous momentum within the sector in charting a course towards zero emissions and towards looking at road towards resilience and health equity. And in that effort, we have now about 67 healthcare institutions representing the interest of over 14,000 hospitals and health centers in 22 countries that are working with Healthcare Without Harm to decarbonize healthcare, its buildings, its operations and supply chains in the race to zero. This momentum is also working at a global policy level. And in that global policy space, last year, with the launch of Alliance for Transformation Action on Climate and Health, an initiative by the World Health Organization sort of clearly sets that global agenda. And the focus of ATTACH, as it's called, is on climate resilient, sustainable, low carbon healthcare. And this is an initiative that follows through the government health commitments made at Glasgow COP26 health program, which has now 62 low, middle and high income governments who have joined this program. And more than 20 of these governments have pledged net zero healthcare. The goal of ATTACH is to ensure that public health is at the center of climate action and countries have the information and tools they need to protect the health of their populations from the impact of climate change. ATTACH also aims to build capacity and support countries in implementing health-related targets of the Paris Agreement on climate change. But it is not enough that health sector charts its own path to a low carbon future. Given the scale of the problem of climate change and climate change induced events directly, how directly and indirectly they affect human health, it's important to be proactive in framing plans and policies to meet the health needs of the affected populations. It's important to see health systems not merely as healthcare providers, but as foundations for community resilience and preventive care. And healthcare also needs to take the lead in communicating to public and how to protect themselves from the most extreme health impacts in this warming planet. Given the scale of problems, health sector also must lead and inspire other sectors to follow suit to protect public health. So this task is not limited within the sector, but we are expecting the sector to also lead in transforming other sectors. And this brings me to the critical role that healthcare professionals can play in advancing this message. Healthcare professionals, we've heard throughout, are the most trusted, and have a very important role in carrying the message to the public. They see incredible sources of information because they see the effects playing out in their clinics and in their hospital on a daily basis. And the COVID-19 pandemic itself has presented as an important opportunity for health voices to be heard and amplified through various media. The reception that we have seen to the COVID-related health message has also kind of reassured that health professionals are still regarded as the key messengers and advocates for health protection. And health workers' voices are critical in promoting actions that address climate change and its impacts on health. And in the last 3 years, health professionals have not just witnessed the COVID catastrophe, they've also witnessed the climate crisis. And they are at the forefront of both this crisis when it comes to taking care of their patients or taking care of their communities and influencing policies. And let's also be aware of the fact that for those who think that COVID-19 was the worst crisis, well, it's just a trailer of what the havoc climate crisis can play on our communities, in our societies, and on this planet. So the health sector overall has a unique opportunity to combat climate change and to help people understand that the same pollution that endangers our health also drives climate change, and fossil fuels is the best example of that. They're a major driver of climate change and a main source of air pollution that causes millions of premature deaths every year, a large burden of which falls in my country, in India. You will see when it comes to air quality, Indian cities make the headlines that we don't want to make, from being some of the worst polluted cities on this planet. So, health professionals are both trusted communicators and important actors when it comes to protecting public health. And in that context, it's imperative that the health professionals are equipped with the necessary knowledge and tools to tackle the biggest health challenge of the 21st century, climate change. And it's also equally important that health voices, especially from the most vulnerable places, get a seat at the table where decisions are being made. Fighting global health risks and diseases, including outbreaks with pandemic potential, are fundamentally about fighting climate change. We must reimagine the role of healthcare in a world where the climate is fast becoming the most fundamental condition facing people in their communities and in their lives. Here is an opportunity for expanding the mission of healthcare. The very definition of quality healthcare needs to be transformed. Healthcare needs to redefine itself in the age of climate crisis to be focused on community resilience, modeling a transition to a post-fossil fuel economy, and being trust holders and messengers to their communities and in support of policy changes. Finally, I would like to say that as the guardians of human health, it is the responsibility of the health sector not only to treat the symptoms of climate change, but also to be at the forefront of efforts to address its root causes. And by taking actions to reduce their own carbon footprint and advocating for climate conscious policies, the health sector can lead in protecting both the health of their patients and the health of their planet. Thank you.
So thank you, Shweta, for setting the context for today's session and why health systems and health professionals are really critical in how we address this challenge. We're going to discuss that in a bit more detail in a second in the panel. But before that, we've got Fazia Rashid, who's advisor to the director at the Aga Khan Development Network. And Fazia previously in the year spoke, she's doing fantastic work around how we measure carbon emissions in health. We've got her back to talk about the role of plastics. And the reason that's important, not just because you'll see some stats up here about greenhouse gases, but in the next slide, if I can move it along. Shweta, can I just grab your... thank you. That plastics in health are a huge problem. That each hospital bed, and this is from Europe, this is from the UK, generate a ton of plastic waste per year. So Faz is going to take us through a little bit about the work that she's been doing, look at some practical examples of what they've been doing in their health system to improve that. So hopefully this will work, and Fazia will join us to talk about plastics.
Especially to the BMJ for giving us a second shot in a short period of time to explain a little bit of our work and our thinking. Just let me start by saying that the reflections I'm going to share with you represent those of myself and Dr. Hais Balravan, who's the Director of Health of the Aga Khan Development Network. I'm a professor at the London School of Hygiene, but also lead the decarbonisation efforts within the Aga Khan Health Services. So before going on to the subject of healthcare waste management, I was asked to briefly describe the work that we're doing more broadly in terms of getting to net zero. And we have made a lot of progress. So the Aga Khan Health Services, for those of you who don't know us, we manage roughly around 500 hospitals and healthcare facilities in 8 countries around the world, all LMICs. And in all cases, we work very closely with government. Now, roughly about 2 years ago, we pledged to reach net zero operations without really knowing if that was possible, but we've come a long way since then. And our target was by, if not before, 2030. So we started with a very ambitious remit, or so we thought. Now, so the obvious place where we began was to begin to start measuring our carbon footprint. And we did that through developing our own tools because we realized that we needed to make it simple if we were able to sustain the effort. And we've done that now for over a year with all of our operations, despite COVID. Maybe because of COVID, our staff just embraced this agenda. And now we've chalked out the way in which to get to net zero for our largest operations. And just to sort of give you an indication of what we're seeing, and we haven't completed the exercise, but for our largest operations, we've calculated and we know exactly what to do to reduce our footprint by 75% in one instance to 85% in another of our operations. That's a huge amount, and we really were surprised to find that that was possible and that it won't take much in terms of time. This is a case of buying equipment and installing it. And the big news item here is that all of this saves us a lot of money. In fact, the returns of investment are so attractive that you can quite literally take the propositions to the bank. And with the increasing prices of oil, the case just gets better by the day. We estimate that on average across our countries, we're going to take about 5.7 years to realize the returns on investment. But in many instances and in many of the actual interventions, the return on investment is much bigger. So back to healthcare waste, or maybe I should just say before I start, is that our approach and our tool has been co-branded and vetted by WHO. And we are now have been invited to share our work with ministries of health around the world. Last week we did EMRO. This week I'm in a workshop with over 20 countries in the Afro region. We've got Ministry of Health and Ministry of Environment representatives here. And they're really embracing this agenda, and we hope to be part of and witnessing a rapid escalation in efforts globally. So healthcare waste and plastics in particular is what I'd like to focus on. Now, when we take a hard look at healthcare waste, the sites are not pretty. And I think it's no accident that we tend to hide our healthcare waste, far from the view of the public eye, because it is a public relations disaster. And when you look at the components of healthcare waste, it is really quite shocking that we have somehow become blindsided to the waste that we're generating, while delivering, healthcare with the best sort of intentions. So in short, what I'm going to try and do here is to challenge the premise that the health sector should get a pass on freedom to pollute, just because of the good work that we otherwise do. It's just, and if we don't sort of act in a bold and maybe perhaps naive way to tackle the issues and wait on sort of others to indicate what to do, I think we're going to lose a lot of opportunities. And I'm going to suggest some of the things that we can do to start now. So to begin with, on plastics, WHO doesn't list plastics amongst what it describes as 10 to 25% of healthcare waste that is hazardous, and for which WHO has guidelines on how to, protocols on how to dispense with, items such as radioactive and, chemical wastes and so on. And yet there's no question, it's almost sort of extraordinary that we need to explain that plastics are a health hazard. So besides, the fossil fuels, the obvious, that are required to generate plastics, we all know that plastics, as they sort of persist in the environment, are breeding grounds for vector-borne diseases. They also block and break sewage systems. They suffocate wildlife, and they leak toxic products into waterways and into the air when they're burnt. And they've also specifically been linked to numerous adverse health outcomes. So while, concerns regarding plastics are not new, there's been a lot of, if you examine the literature, focus on recycling. But really, I think it's time to reconsider the use of plastics altogether. Partly, the literature is also focused on recycling medical plastics, and that's, we know, is not an answer. Roughly, and this is probably an overestimate, it's estimated that 9% of medical plastics are recycled. But where plastics are recycled, the manual process of sorting through the waste represents real healthcare risks for those involved. And recycling needs yet more energy, depends on infrastructure that few of our countries have, and doesn't resolve the central problem. You still end up with persistent products that are problematic. Now, in terms of volumes of plastic that healthcare operations generate, it's really quite hard to tell. I haven't been able to find, information that was sort of useful to share. But WHO will categorize 85% of the general healthcare waste, which is clearly most, to constitute mostly cardboard, paper, and plastics, and it lumps it all together. In our case, when we look at the general waste and open it up, and I'd encourage all of you to really sort of start opening some bags around the back of your facilities, it all pretty much all looks like plastic. And that's probably because in our instances, paper and cardboard tend to be recycled. Now, where does it all come from? So the answer for most of the plastic in general waste is food. Wrappings from junk food, food containers, plastic bottles from water and soft drinks. And next come plastic containers that are used for housekeeping in our healthcare facilities, cleaning products, chemicals, as well as plastics from packaging, including styrofoam boxes, bubble wrap, plastic sheeting, and the like. All in all, when you look at it, it looks remarkably like domestic waste. And probably because it looks so much like domestic waste that we've become used to seeing, we've sort of overlooked it. But it is a horrific sight when you sort of, really consider the long-term impacts of it all. And plastic items that are specifically medical include gloves, PPE, syringes, tubing, speculums, and the like, as well as plastics from packaging for sterile items, and containers and blister packs for medicines. So what can be done? So I'm going to start with plastics that we incinerate and burn. And because fossil fuels are used in the process and because of the air pollution that this generates, and of all medical plastics, apparently around 12% are supposed to be incinerated. We know in our countries, a lot of plastics are also burnt just to get rid of, if you like, waste that is typically, associated with healthcare facilities, and because of the sort of public concerns when people identify waste that comes from healthcare. Now, a recent audit of some of the products that we're incinerating in one of our.
So I think we've lost Fazia. That's fine. I think we captured a lot of what she had to say, and hopefully we'll get her back later. But what I'm going to suggest we do is we crack on with our panel discussion. And I'd like to ask Ariel, Renzo, Shweta, and Natapan to come and join us on the stage. We want you to think about your questions as well. So we want this to be interactive this afternoon. We're going to do this in two parts. We're going to have some panel discussion now. Then we're going to see some short practical examples of nurses, doctors on the grounds who have done projects in Nepal, in the UK, and in the US. And some of you, I know, came into the session early today, and we asked you to speak to your neighbour and share practical projects you were doing. So we'll hear some of those as well if you want to share those this afternoon. What I'm going to do is I'm going to ask our panelists to maybe just give us a quick introduction and some opening remarks. But I'll give you that microphone. Have you got a microphone? Wonderful. So let us start from Ariel on this side. What I'd ask you to do, maybe to do a quick introduction, tell us who you are, where you're from, and I know some of you already have some thoughts or opening remarks for this session, so maybe this is a good time to share those.
I'm Ariel Pablos. I'm a Mexican physician and a professor of medicine at Columbia University in New York.
Okay, I'm Natapan Supaka from the Thai Health Promotion Foundation of Thailand.
Thank you.
Hi, everyone. I'm Renzo Ginto. I'm a physician by training from the Philippines, and I'm the director of the Planetary and Global Health Program of the St. Luke's Medical Center College of Medicine.
Wonderful. And so we've met you already, but for people who've come in late, maybe just a quick introduction.
So I was just going to say that. Hello again. I'm Shweta Narayan, Climate and Health Campaigner with Healthcare Without Harm.
Wonderful. So I'm going to turn to our panel first of all. It's just reflections, I think, on the last couple of days of PMAC, their own experiences in their own countries. So we'll go through each of our panels one by one. We've got some questions, but I'd love to hear from you as well. So please, as we go through this, think of your questions, think of your examples for the panel today. But first, Ariel, over to you.
Well, thank you very much, Ashley. And after this morning session on revolution, I feel like we are a bit more focused, but hopefully it will lead us to action, which is also what we all want. It is clear the health system not only care for the illness that is coming out of the climate change, but it's also a vulnerable part of society. And a third dimension is that is what we are addressing today, is how we also, the health systems, contributes to the problem. And while not part of the Hippocratic oath in medicine, we all go by the ethical principle of first do not harm. And we have to wonder how much this is a problem, bring consciousness and the like. Health is, of course, more than health care, but the health system consumes more than 95% of the resources devoted to health in most societies. I practice medicine in the largest hospital in New York, and as you're working, you almost forget the larger dimensions of your impact as you're trying to address the needs of patients before you. And while there is a vast literature on do not harm in terms of the patient safety movement that has been successful, I think, in America and in other places, the ecologic window is often less visible to us when we are in practice. And well, many organizations are already trying to do, of course, a lot of work, traditional work in reducing chemicals and plastics and so on. But when it comes to climate change and greenhouse emission, I think we have been less mindful of. I mean, the pollution has been, I remember New York in the 80s and 90s with syringes washing ashore in the New York Bay. We have come a long way since those days. But again, we have to do the same thing beyond that. In terms of the more direct pollution and plastics efforts, this week we visited the Chula Zero Waste, Chula Longhorn, quite impressive in putting zero waste to landfill. It has been there for the last 5 years. A great success with surpassing their goals now, almost 50% reduction in waste, which, as we heard earlier, shows that it's possible. And Thailand now has 36 members of a sustainable network of universities doing the same thing across the whole campus, not just in the health care component. And we must lift our sight from just direct pollution of the healthcare sector to greenhouse emissions. And I was happy as a relatively new student of the climate challenges to read the Healthcare Without Harm report that did the first global analysis of the footprint of our sector, and it ends up being about 5%. It's quite significant. The World Bank has done their own estimates, and they're all about there, and in most countries that seems to be the case. And not surprisingly, the top three emitters are the United States, China, and the European Union, accounting for 2/3 of all the greenhouse emissions by the healthcare sector. They also count by as much in the health spending, so there's a link into the spending and the pollution and the greenhouse emissions. And the main ways in which this contribute, we heard them already: energy consumption, transport, manufacturing, the supply chains, which we don't think of very much, when we should, of course, be mindful only to make sure we get things that need to be reached in the communities, but also the best way to do that. The supply chains accounts for 70% of all the problems. So it's energy consumption, but it's all that happens getting in and out of our clinical settings. And one of the posters here also this week documented the greenhouse gas emissions of hospitals, and they found that about 82% were attributed to patient travel. So we often don't think that, but obviously that's part of the healthcare system that we have created. So that is where the money is. A lot of the energy consumption, logistics, supply chains, and it's hard to argue, of course. You do need electricity, but you have green ways to generate the electricity, and much more could be done nonetheless to reduce people transport and supply chains emissions as we move towards universal health coverage. And I was also happy to read there are many countries that are moving, of course, already. Looking at the UK, the NHS, I think it's quite encouraging. Although they have many challenges, as we have also heard, from 1990 to 2020, they were able to reduce greenhouse emissions by 26%. They are now probably more than that, and they're now hoping to reach the world's first net zero emissions healthcare system. So these are positive deviants at the moment, but they show us what is possible. And it's great to see in the reports, of course, what they do. There's a lot of very specific actions, and most of them are actually cost saving. That's so surprised that you will save money to do the right things. So the solutions exist. We need to do a lot more on telemedicine and e-health, and we geared up for that because of the COVID crisis. And but as we wind down back, we are going back to the usual ways, and the payment systems, insurance companies, Medicare, Medicaid, not often cover all of those visits. So having systems that allow us to minimize transport, maximize access, e-health has an opportunity. Green energy hospitals increasingly becoming part of the zero emissions efforts, ambulances that are zero emissions. So there are many activities which are, again, quite systematically listed, and we can take them on because they will be cost saving. I think invitation, the WHO has seen 2/3 of countries do now a climate change assessments in their health systems. But most of the countries, especially low middle income countries, do not have the resources to really go beyond their usual to make these changes. So it's an opportunity for donors to assist, but also to help build climate-friendly health systems. A global health system with zero emissions is now conceived as a possibility by 2050, and I think we can all guide our efforts this way. And of course, we have to go beyond our direct footprint to be advocates to decarbonize our national supply chain and the broader transition to clean transport and clean energy. There's the need to focus more. A lot of these will seem like operational, but even that requires research. The best way to do it, the best way to maintain our services and also save the planet. The literature still is thin. I mean, the research itself probably will benefit here to link that directly also to health outcomes. We just heard yesterday in the metrics session that our models, the epidemiological models for global burden disease, are not quite taking into account temperature change. And I think we all need to put our minds there in a way that is authoritative to make those linkages as a health community. And also we in the global health community have a special responsibility as well. When I was at the Rockefeller Foundation, my boss, president at the time, Judy Rodin, was it, you guys in global health, you are traveling so much. And it was a complaint. And I guess they were jealous also because in global health, we did accomplish a lot during the MDGs periods. And I think it's nonetheless important that air traffic is almost as big as the healthcare sector in contribution to greenhouse emissions, and is bound to double, so that an international conference in person is like 100 times a contributor to greenhouse emissions compared to one that is virtual. I mean, computers also generate greenhouse emissions, but much less if you do Zoom than if you travel, as I did just last week from Mexico here. So I guess guilty as charged. And as someone who has attended all the PMAC conferences, I guess I felt some remorse. And I believe, and I was telling, Professor Vishan Pranish, that maybe that we need to institutionalize these virtual participants. Seems like a residual of the COVID period, but should instead be an assertive way of doing business in this conference, and hopefully develop technological excellence in doing that very well, so that we can also inspire the thousands of health professional conferences that occur around the world. And so I think we should think twice about our carbon footprint in our travel. And I certainly, I'm very happy that PMAC has organized a lot of the virtual participation, including some of the panel drivers. And I want to see a lot more of that in the future. Thank you.
Thank you, Ariel. And you mentioned Nan, and we saw you, I think, on the video yesterday in your stunning PMAC green T-shirt whenever you were up visiting. Just a show of hands, who was lucky enough to go on the field trip to Nan the last couple of days? Quite a few people. So I think we'll come back to this later on, but we, people who visited, saw the challenges of the local population, healthcare staff working in an area of deforestation. And whenever we're talking about engaging healthcare staff in greening health systems, there is the question about equity and the fairness of how we expect staff who are working in very difficult situations to prioritize greening their health systems as well. We'll come back to that in some discussions in a second. But next, I want to hand over to Nutpan, who's going to, you've got some slides as well to talk through in your opening remarks from Thai Health. Nutpan.
Thank you very much, and good morning, everyone. I think the Thai Health Promotion Foundation, we are not at the healthcare sector, but we work under the health system in Thailand. So I would like to introduce about some real example that Thai Health work with the environmental and some natural crisis, something like that. Next slide, please. Okay. This show we are the government autonomous government agency under the Health Promotion Act, and we share by the Prime Minister of Thailand with the multi-sectoral ministry, and we use we call the dedicated tax from the tobacco and alcohol, and to the gets for the health promotion activity. Okay, next slide, please. And this is the vision. You can see the vision is all people living in Thailand have their capability and also live in the conducive environment that have the good health. From the mission we are do forward. First one is inspire, motivate, coordinate, and empower individual and organization to have their capacity and conducive environment. Thank you. Next slide, please. This show the 10 years goal of the next decade of the Thai health. You can see the goal is the good health and well-being for all. You can see the strategic priority area that we work. You can see a lot of the NCD, road safety, and also the environmental pollution, and also the health crisis, something like that. We work with the multi-sectoral partner. You can see next slide, please. Okay, this is show our mechanism. Because the Thai health is very small, but we work with all sector in the Thailand, for university, civil society, mass media, local community, and also everyone can work with us. Every year we get the healthy project, maybe more than 3,000 projects per year. We look like we are only the catalyst to move all the system to work together. Next slide, please. After that, I will show the time to action. This is the real example. The Thai Health and the partner work with in the aspect of the environment protection and also the natural crisis. Next one, please. And I think the first one is to create the cross-sectoral engagement by use the tri-power strategy, because Thai Health and the partner, we work together in the triangle. First, we use the knowledge from the research and work together with the social mobilization and the civil society, and also maybe through the policy advocacy and law enforcement. All of them can synergize to move very difficult problem. For example, NCD on environmental crisis. Next slide, please. And we try to develop our organization as a model because last 2 years Thai Health we received the platinum from the reading in the energy and environment protection from the US because we use some the initiative. Next slide, please. This is show our model. We try to connect all of the innovation or creative. For example, we use the sun roof to maybe the sell electric in the building. We have some the farming. I think we call the urban farming on the top of the floor. We have the public space and also use the some light and from protection. This idea is collect from our partner or many aspects together. Next slide, please. And another aspect, we try to use the driving of the healthy meeting movement. You can see the PMAC. It also we adopt the healthy meeting into the guideline to maybe the environmental protection and also the good health. You can see next slide, please. This is the key component of the healthy meeting. You can see tobacco free, alcohol free. We have some more the physical activity and also we use the environmental friendly, not used by the single use or plastic, something like that. Next slide, please. And another aspect that we work, we have the healthy diet plan. We try to the sustainable food supply chain for me to protect the malfunction and maybe take too much food, maybe the sugar, starch, and salt. And also we try to have the Thai people eat a lot, enough food and vegetable, something like that. But we work all together in the food supply chain. Thank you. Next slide, please. And this is our work. We work with the architect network in the Thailand to design and improve the area space of the public hospital in maybe 20 hospitals in Thailand to maybe environmental friendly, and also we have the good quality for the doctor, health staff, and also the patient in hospital. You can see this model. Next slide, please. And another aspect, we have the suffer in the northern of Thailand in the summer because we have a lot of the PM 2.5. So we try to initiative, we call the Boost School. We try to make the student can protect themselves by use the wear the mask and also use the application to detect the small smoke heat spot and can to relieve to mitigate of the PM 2.5 crisis. Next slide, please. And I think another aspect, the Thai Health will work with the maybe 3,000 community in the Thailand to make their resilient for the natural disaster and also the pandemic. The good example is for the pandemic, for the COVID to last 2 years. Our community work together by use the reader in the community to resilient and have some the health intervention to mitigate the crisis, something like that. Next slide, please. And this finally, I think very important work is to empower the voice and the voiceless wisdom for the vulnerable population, because this group of people may be more suffer from many crises. Thai Health, we have another specific plan for the vulnerable, for the healthy people. So you can see some activity. Okay, final slide. This is in the last 2 years we have received the Nelson Mandela Award for the health promotion from the WHO organization. We use from the financial to promote the health intervention, and also we try to improve the health outcome in the people of Thailand. Thank you very much.
Thank you, Nodapan. Renzo, so you've been moderating sessions the last couple of days. We've got you in the hot seat today. Share some of the thinking that you've gleaned over the last couple of days.
Yep. Thank you, Ashley. And yes, it's great to be on the other side of the conversation as a panelist this time. And thanks to all the earlier remarks that have been given, especially Shweta's framing presentation about the importance of climate mitigation, decarbonization in the health sector. And coming from the Philippines, a country that is already experiencing climate change, already facing the health consequences of climate change, indeed, we need to make sure that our healthcare sector is able to adapt to the changes, but also is not contributing to the climate crime. It will be, I guess, antithetical, right? That we, as a health sector, are trying to address the diseases on one hand, and we are also contributing to the carbon pollution on the other. And, Ariel, you also alluded to the do no harm tenet of our profession, which really, I think, should be the central, principle in this work we have in addressing climate change and health. But of course, we need to also remember, especially in low and middle income country context, that climate mitigation, decarbonization, especially within the health sector, is not an easy task. First, health professionals in general are not really educated, trained, aware about climate and health in general, but also, these important tasks that need to be done in order to address climate change, whether it's mitigation or adaptation. The health sector is also generally disconnected from energy policy, the energy sector. And as you know, the passionate conversation that we had 2 days ago on fossil fuel, energy, and health is, I think, a testament that we need to be, more aware, more equipped, better equipped as a health sector to not just understand and analyze energy sector issues, but also come up with the solutions that will allow us to transition to green and healthy and just energy systems. Also, I think there's very limited recognition of the importance of the health sector at the country level when it comes to energy, climate change. For example, in the Philippines right now, yes, we have a moratorium on the establishment of coal-fired power plants, but there are now difficult discussions about whether we should go nuclear. And this is an area where the health sector really needs to step up, not just because these energy systems will be powering our health facilities, our healthcare systems, but also the broader community and the nation. So these are just some of the challenges. And yes, it's easy to think about the technological solutions on how to improve energy efficiency in hospitals, or shifting from bad and unclean fossil fuel all the way to or towards solar power. But really, what needs to happen within the health sector is to equip ourselves, to be more engaged, and really to have that know-how and that capacity to usher these changes that we want to see. So that's my first comment. I think the second is, we should not forget, we're talking about decarbonization, but there are also unfinished businesses in the environmental footprint of the health sector. We're still not doing a great job in terms of managing water use, chemical use, all sorts of pollution, healthcare waste management. All of these certainly separate issues, but deeply interconnected to the broader climate and planetary crisis. Also, for low and middle income countries, yes, we need to contribute to decarbonization, to reducing our own carbon footprint. But also, I think we should never forget that adaptation and resilience building is very critical. You have health facilities, for example, in the Philippines, that are not only energy poor, because they don't have access to reliable electricity to power your operating theater or, the emergency room, but also these energy systems and health facilities can easily be wiped out by a typhoon that is becoming more and more frequent and severe and in intensity in a place like the Philippines. So, there's one concept that we use in healthcare without harm, climate smart healthcare, which is the convergence between adaptation, making sure the health sector is the last sector standing, but also mitigation, not contributing to carbon pollution. And that is, I think, something that we should actually try to really embed in the operations of the health sector, not just an add-on, but really part of the health sector's DNA. And lastly, I think, what do we need to do moving forward? Ariel already alluded to the importance of research. There's so many things that need to be, worked on and studied. And there are two things that are quite relevant to my experience. One, I'm chairing the thematic working group on climate resilient and environmentally sustainable health systems of Health Systems Global. And basically, the health policy and systems research community is now starting to pay attention to the climate crisis and how can we redesign new healthcare systems that respect the planet, but also address to the changes that the global environmental challenges are presenting to us. And also, I'm actually joining a new Lancet Planetary Health Commission on Sustainable Healthcare led by Jody Sherman from Yale and Alice McNeil or Andrea McNeil from the University of British Columbia. And basically, this group of academics from different disciplines will be looking into what are the solutions for the next several years and decades to make sure that our healthcare system is climate smart, both resilient and low carbon. I think we need to do a better job in educating our health professions. I think climate and health literacy should be central, should be natural to the healing profession. And so we need to make sure that all curricula around the world is already incorporating everything that we discuss in this PMAC. In fact, there's a global consortium on climate and health education that you may be interested in learning about. And if you're a medical school, a public health school in this room, please join the consortium so we can all learn from each other on how to educate the new generation of health professionals who are climate resilient and climate smart. And finally, I think ultimately, there's a tendency to focus on the technological solution, solar power, plant-based diet, etc. But I hope that this conversation around reducing the environmental impact of healthcare will open a much broader discussion and dialogue on the transformation of the healthcare system and the global health system that is required, from the way we finance. I think in this day and age, every global health funder should be incorporating climate considerations in their funding decisions. The supply chains of our, major pharmaceutical companies, and many other aspects of the global health system. So I hope we don't stop with, making sure that hospitals have the electricity that is needed and the resilience that is required, but ultimately we ask ourselves the hard questions that will bring our 20th century health system to the 21st century and the challenges that it's presenting. Thank you very much.
Thank you, Renzo. I want to come back to two of those points in a second, particularly the one around how do we engage healthcare professionals. But I want to check, first of all, Sweta, you've already given us a fantastic presentation. Anything you want to add to that or any other comments so far?
Not really. I was just thinking about it that one of the advantages of going last in a panel is that you don't have to say much. My co-panelists have already sort of outlined and given a very deep dive. One thing that I definitely, which is kind of I've been stuck by in the last 3 days of conversation, and especially after the morning session on social movements and health, is that increasingly with COVID pandemic and now with more and more visible impacts of climate crisis, I think this is a moment to kind of rethink the way our health system is designed and also move away from the hospital-based care to more transformative community-based care, and where resilience will be inherently embedded in the way we approach. I think it's a moment and an opportunity in that sense to kind of transform the way we see health care in communities, and this is also a moment to think about and very prominently place equity on top of everything that the healthcare sector does. And this is an opportunity. And for me, that is sort of very, very strikingly evolving as I'm interacting and listening to the magnificent speaker lineup. And just one thing that I'm always kind of, we keep talking about health in all policies. This has been always there, but somehow it sort of gets put in the back burner. But during the Kerala floods, when we did a study of what was the response and the impact of the healthcare, and how did the healthcare facilities manage during the flood, and interacting with especially nurses who were on the front line providing rescue and support services, I was struck by something that one of the nurses told me. And she was quite agitated. In the landslide, her house was gone, and the health facility was providing shelter to her and everybody in her community. And she kept saying that, you come to the healthcare providers and health services in times of crisis. But if you refer to us before the crisis, there won't be a crisis. And I think that is really, really, that strikes a chord. And that's something very profound that she had said in her fit of rage, which I think we need to continue and integrating that message in the work that we continue to do.
Thank you, Sweta. So I want to get you in the room involved. So if you've got questions, if you've got comments, if you've got reflections on what we're talking about today, catch my eye and I'll either bring the microphone to you or we'll get you up to one of the microphones in the room. So just give me a wave at some point during the session. But I want to kick off. We had two questions at the beginning of this session. One, did you feel your organization was having a negative impact, damaging the environment? And the majority of the people in the room said yes. And we asked the question about whether you felt empowered to go back and make a positive change in your organization. And we had a bunch of people, I won't pick on them at the back of the room, who said no. And of all the events we should be at, this should be an event where we feel empowered to go back and make a difference. But I know I trained as a doctor in the UK. All my friends who work there at the minute, they're burnt out. They're dealing with 7-hour waiting lists, our waiting times in emergency departments. There's a shortage of beds. There's issues around costs and inflation in the UK. Looking after the environment and managing reductions in plastics and turning off their monitors at night time to reduce carbon emissions is one of the last things on their mind. So I want to turn to our panel and see if we've got any reflections about how do we engage these very stressed, very burnt out, very busy healthcare professionals to getting engaged in this movement. And we need to do that. We're not going to achieve this unless we engage that group. So I'm going to open this up to the panel. I'm maybe going to pick on Renzo first of all, because Renzo, whenever I go to a conference, Renzo has his fan club who come up to him after the event as well. So if anybody can inspire young people to engage in this movement, it's Renzo. What are your reflections, Renzo?
Yeah, well, on education. So for example, in the Philippines, last year, we actually piloted a course on climate smart healthcare in developing country context, because we're realizing that, yes, the UK NHS is a role model for the world when it comes to climate mitigation within the health sector. But there are specific realities that we in low and middle income countries do experience that will need to be addressed head on. And so, we designed that course to really kind of equip hospital administrators and public health professionals on how to start their climate smart healthcare projects within their own organizations. So I guess we need more of these kinds of initiatives. And again, I'm speaking to the educators in the room because time is running out. And if we're going to address the health, the environmental impact of the health sector in the next several years, then we really need to, in a way, multiply our tribe and really have more young people, health professionals, students, etc., being involved in this cause.
Renzo, anybody else in the panel want to reflect on that? Shweta.
Yeah, I'm just particularly reflecting on what you just presented about the state of or the stress among the health professionals in the UK with everything that is happening around. And just also kind of we always seek solidarity and evidence and support and scientific information and research from the health community to advance the larger environmental justice agenda. I think this solidarity works both ways, and recognizing that the health professionals have been stressed for a few years with the pandemic and with everything else that's happening around. I think this is also a moment for communities and other movements to lend their solidarity in advancing their demands and agenda, and especially when it comes to building capacity, providing more financial support in upgrading systems, and because all of that eventually goes back to better environmental health situations in the community that reduces the disease burden and hence the stress on the facilities and people. So I think I see the role of lending and seeking solidarity fundamental over here, so that it's not like healthcare professionals are there to serve us when there is a crisis, but also lend support to them and their demands to make situations better and have better capacity and better equipped professionals who are ready to support us when we need them.
Thank you.
A good question. Again, compared to this morning, the session we had on taking down capitalism, clearly doing better in our clinics in the hospital sounds more doable. And I'm impressed now by the fact that we know what to do. I'm impressed that it's being done to some extent, but it's also faced many challenges and complexities. I think that I was the head of global health at USAID, and we had a vision to end preventable child death. And it sounds like a very lofty vision, but it's actually happening, right? So in 1970, you have 17 million child deaths. By 1990, 12 million. Now we are less than 5 million child deaths. And so we are on our way despite climate change. And this creates a dissonance to the message, to the practitioners, especially when now 60% of the deaths of children occur in the newborn period, often in the first golden minute, asphyxia and dystocia and so on. And so those who are dealing with that, making the connection to climate change and global warming is difficult. So making sure we get that connection right is very important, because practitioners are no nonsense. They are dealing with a lot of other issues. And so making sure the evidence is clear of that connection, and also being honest when that is not the case, so that we can indeed focus the energy in a pragmatic, constructive way. Conscious also of, I've been a champion for the global movement of universal health coverage, inspired by Thailand and many others. But I mentioned, I alluded earlier at the relationship between health spending and the carbon footprint, which is not surprising. And I want you to imagine the following, because from the health financing world, I see a parallel here in terms of the challenge. If you are a poor country, 1,000 income per capita, and you spend 3% of your resources in health, that's $30. You have not even the basics can be afforded. As you move to middle income, 5,000 income per capita, and you spend now 6% of that bigger economy in health, that's $300, tenfold increase. And then when you're a rich country over 10, 20,000 income per capita, and you spend now 10% or more of your GDP, all the way to 20% in the United States, the biggest economy in the world. Why do I mention this? Because in the health system, there's a transformation you move from 3% of a poor economy to a 6% of a bigger economy. And the transformation means, unless we have a revolution in the health planning sector, you see an explosion in the provision of unregulated private health services. You just see pop-up doctors' offices and little clinics everywhere. And so compared to the UK with the NHS, where they can have a system, and here in Thailand, the National Health Security Office, which was the major accomplishment of the USC movement, covers maybe 70% of the population and accounts for about 50% of the spending. They have an opportunity, but they do not control the civil service insurance scheme. They do not control. Now, the minister may claim to control it all, but when you actually have situations like in sub-Saharan Africa, with 50% of the spending is out of pocket, or in places like India or Myanmar, when it reaches up to 80%, that means there's a lot of little clinics here and there. So the health sector is something nobody really can grasp. So it's a challenge we had to be mindful of. And as we all built systems towards universal health coverage by virtue of arranging the financing, maybe there's a way to marry the USC movement with the climate change movement to ensure that we build systems that are coherent and that address both the financial protection needs of the population, health access, as well as climate change.
Thank you. Nudman, do you want to add anything to that? Or
I think for the main challenge is to engage the non-health sector, really challenge. And I think some example of the Thai Health Promotion, we try to have some initiative to make more the collaboration with the non-health sector. For example, we get maybe some innovation awards for the student to get the idea to decrease the waste and protect them from the environmental crisis, something like that. And we have a training course for the health professional to work with the reoriented aspect of the health. And we try to work with the public sector to maybe some collaboration project to CSR project, something like that.
Great, thank you. Thanks to all the panelists for their answers and questions. I'm going to come to some questions from the audience. We'll go there first of all. You wouldn't mind taking the microphone on the floor, that would be great.
Thanks so much to the panel. Absolutely fantastic. So several of you have mentioned about decarbonizing healthcare in low and middle income countries. I'd really like to hear a little bit more about potentially the specific challenges that occur in these contexts. Ariel mentioned about the UHC agenda, for example, and we know that that requires a lot of new health facilities to be constructed. So there is an opportunity here to do that in a green way. Now, the question then is, I think, Ariel, you mentioned it as well here about funding. You know, other opportunities here for donors, is that what's required? What do you think? And if you just put yourself into the position of a policymaker, what are their challenges? I wonder if you could draw on your experiences in your own countries. Thank you.
We'd like to take that first of all.
Maybe I can talk about some of the crazy things that we have in health financing. There are many paradoxes, and I believe misunderstanding is one of the biggest ones. As I said, the first one is to understand that health spending will grow with your economy. It's not the case for agriculture that shrinks as your economies grow, or manufacturing that eventually shrinks as your economy grows. Health spending and education, to some extent, will grow with your economy. This is very important because at the highest level, one of the first barriers is to convince the ministers of health, even the minister of finance, that health spending will grow faster than the economy, faster than the other sectors. And this is like an impossible political proposition, and yet it's a fact. So unless you understand, plan for, and decide how best to invest those resources, you end up with a badly formed system. In 1992, Hillary Clinton, the United States, tried to advance universal health coverage. We had 60 million Americans without health insurance, 20% of the population. We were spending $720 billion in health. And when the Republicans said, oh, we're already spending too much in health, even the Democrats said, yeah, we're spending too much, must be the evil pharma, the evil this, the lawyering that we need to cut back. Not so. But we were also coming out of a recession, so we did not, the reform didn't happen. We come back in 2010 when I got to Washington, and we were now spending $2.7 trillion. So we went nearly threefold increase in health spending. threefold increase in health spending, and still 20% of the population without health insurance. So the question was never, can we afford another $1 trillion in the United States? Is we will spend an additional $1 trillion. What is the best way to invest it? And if we change the question, if we can show the evidence, if we ourselves became more familiar with these macro issues of health financing, we will be empowered. As they do here, for example, you don't even have to fight too much. If you know this, what I just said to you, you don't have to cut back budgets in some of the other things. You just need to not grow and let all the growth happens in the right ways. So there will be money. Half the countries that were very low income in the year 2000 are now already moving into low to middle income. So there's been an economic revolution in the world. There are many countries, but still is only a shrinking number of them that will remain highly dependent on assistance, may not have even sufficient for the basics. But the rest of the world has already changed. Middle income countries facing the same question. So understanding health financing, I say, is so important to make the case, because you will require investments, yes, in the provision of services, and then smart climate inventions to go with them.
So, I mean, one thing that I've experienced in my interaction with policymakers, I mean, we keep saying that climate crisis is a health crisis, but the way the governance system is designed, everything is very siloed. So a lot of the time we spend in terms of educating the health policymakers that climate change is very much a health problem for such and such reasons. Because the moment you say climate smart, climate resilient interventions in your systems, they will send you to the environment department or the energy department. So I think the first challenge that we face is kind of understanding how interconnected these challenges are and how action needs to be taken in a collaborated format where and sometimes so in a lot of the work that we're doing right now is kind of educating policymakers why they need to take energy decisions. So when they're building and again we are seeing this again from an India perspective, post COVID, a flurry of investments in kind of developing new health infrastructure, and the moment you talk about low carbon buildings, you're sent to a completely different department and it's not anymore a health department decision. So understanding how these decisions and policy interfaces work in those specific geographies is absolutely essential, and kind of dismantling some of those structures and kind of bringing the different departments together, unsiloing, if that's a word, some of the ways in which we have been making decisions is absolutely important. And that's where we see most of the influence in terms of progressive decision making, integrating climate and health.
I'll just add briefly, Shweta, you mentioned about infrastructure. And, as part of the universal healthcare campaigns around the world, for sure, what is already happening is a surge in infrastructure projects. And for example, in low and middle income countries, including the Philippines, because of the climate crisis that is already happening, I think the first consideration first is for the hospital or the health facility, to be safe and to be adaptive. And the challenge now really is how to incorporate, low carbon and environmentally sustainable, because we need to address healthcare management, waste management, and water and chemicals into that infrastructure program with a focus on adaptation and resilience. In the Philippines, for example, for the past maybe a decade or so, the country has already built a safe hospitals and health facilities program. And then only recently, they actually added green and safe hospitals and health facilities program. Now, making it more explicit that the hospitals should also embrace low carbon, technologies and measures. Of course, the challenge also is resources, financing for those technologies, know-how. I can only count by the fingers who can actually advise Philippine hospitals on how to, green their operations. And so, yes, there's already a policy, but the execution will require more resources, human, material, and monetary.
Any final reflections from the panel on that topic?
I think for this, to try to for we try to make some the model development to prove this concept is can make in practical for something like that in the green and sustainable hospital. Is the Thai Health work with the architect network. We can develop that you can decrease the energy and save some the resource and make this is for the policy advocacy. Try to make in more scale, in more maybe 100 hospital in Thailand, something like that. Our work is to make the model development to the real example. Okay, thank you.
Great, thank you. Earl.
Yes, since we came down to the USC, of which I'm a champion and so on, but also these years, the World Health, the UN General Assembly, we have high-level meetings, tuberculosis, universal health coverage, of course, climate change. I think it's an opportunity. We had a session on USC here, and our colleagues from Thailand have been driving the resolutions for the Executive Board of the World Health Assembly. Maybe this session, rapporteurs, whoever the rapporteurs are, may want to send this message to encourage bringing those things together. Because, again, the investments for universal coverage are investments that need to be guided. And so far, I didn't see that connection being made. It should be obvious, but it wasn't so to do so. And I also alluded earlier the issue of honesty with the evidence. And I think I don't come from the climate community, but looking at the subject for these discussions, I was very impressed with the very concrete actions that we can take when it comes to a hospital. And I think we should, there's a lot of that we can do. It's just almost self-evident. But also in the bigger advocacy, we had to be a bit more focused because climate crisis is a health crisis. And then that message, which is important because, in fact, in the communication sessions here 2 days ago, it was clear that if you can make the linkages to health, then people will be more receptive to your climate message. So that is good. But if we don't do it right, we lose credibility. And so yesterday at the metric session, Professor Stein Emil Volset from Norway, who is now the head of future health scenarios forecasting at the Institute for Health Metrics Network, which is really an incredible platform for data and epidemiology, presented his epi-modeling vision for 2050 and dropped temperature from the model. I guess nobody paid attention, but I, of course, came at the question session. So, if you drop temperature of the model, how do you get an invitation to this conference? But the fact is, he dropped from the model. So what does that mean to us in health? In his model, 2050, the global burden of disease will be driven by behaviors, smoking, obesity, and the like. And pollution comes out strong, still as a very important one, 10 times or more important than the temperature, which eventually drops from the model. And I also would like to say that maybe pollution, simply from a tactical point of view, you are more compelling with the initial sensitization of the pollution argument, because it's, again, self-evident and also the data is clearer. And then bring that consciousness, then build it up. But if we tell them that we're dying because of climate change and the epidemiologists don't show us that, then we have a problem. And we heard Magnusson, one of the plenaries early first day, sort of reflect on the fact that, you see, with COVID, we all changed, right? Masks and airports. 9/11, after 9/11, all of the airport security lines, we all went change. And we have this climate crisis and the message of crisis, and then there's no change in the same way. And that deflates the messaging. So I'm just inviting to be honest, targeted, and tactical. Will be my advice. I'm not an advocate, you are, but I will advise that as someone who will be or have been recipient of such messaging.
Wonderful. Thank you for all the great answers, and thank you for the great question as well. I'm going to call an end. We're going to call this round one. So this is the end of round one for the questions for the panelists. I'm going to let our panelists go back to their seats and get her a drink of water. We're going to take some questions in a moment, but one of the important things for PMAC is we've been talking a lot about how we do this. We know that healthcare professionals need to see practical examples of how they can do it in their own environments, in their own health systems. And if you haven't seen them already, there's fantastic posters down the corridor of projects done by students, healthcare staff who are here. And in the run to PMAC, we asked for a call for posters, but BMJ Innovations, which is our health innovations journal that showcases new ideas, we called for projects from around the world that were reducing the impact of healthcare in the environment. We've got 3 very short videos, a couple of minutes each, from Nepal, from the UK and the US, that are individuals who have done projects that we think are quite interesting as well. So I'm going to let our panelists go to the table so they can watch the videos. And I think we'll skip the slides if that's okay with the technical team, and we'll just go straight to the 2 videos if that's okay. So we'll let you listen to these and we'll come back and have your questions ready for round 2, which I know will be tougher than round 1. And apologies, it's my fault for skipping the slides, but this is great. Thank you.
Thanks again for letting me take the time to talk about our program here at Boston Medical Center. We have a program that we're very proud of called Nourishing Our Community. We started this 20 years ago with the first of its kind therapeutic food pantry. And the way that started was to address food insecurity that we were seeing with our, in this case, pediatric patients. So one of our pediatricians went to senior leadership, said we have to do more for these patients. And we did. We started off on a smaller scale with a.
It doesn't matter which order they're in, so we can.
Worldwide, only around a third of hospitals and healthcare facilities have even basic systems in place to manage healthcare waste. We advocate for steam-based technologies like autoclaves or microwaves to treat infectious waste, but the problem is that they aren't suitable for pathological waste. So healthcare facilities still often have to burn it or dispose of it in pits. We identified biodigestion as a safe method to treat and dispose of the organic waste from healthcare, especially placentas and food waste. And we worked with designs already in use for the agricultural sector in Nepal, modifying the layout based on infection control principles. Our recommended design includes 2 underground chambers in series. These are seeded with cow dung to provide the methanogenic bacteria to break down the waste. And one of the byproducts of this process is biogas, which can be used for cooking or heating water. Waste moves through the system by gravity, and at the end of the process, it flows into the sewer without further handling. Blood-borne pathogens that may be in the pathological waste don't last long outside the body. And since the waste is in the digester for several months, the chances any of them surviving the process is very small. Then, of course, directing the treated waste into the sewer breaks the cycle of infection and adds an extra layer of safety. Once the digesters were built and seeded with the cow dung, they worked well. Most teething problems were caused by people not following the procedures, and we were able to solve them with the support of the national biodigester experts. Our results also shows that they can save the hospital money and reduce their carbon footprint. Instead of paying to dispose of food or pathological waste, every ton of material digested generates biogas worth almost $30, and burnt using it for cooking then saves over half a ton of carbon dioxide equivalent compared to disposing of the waste in pits or landfills. Biodigester is particularly well suited for hospitals that generate large amounts of organic waste. The primary concern is usually pathological waste, But since food waste will attract disease vectors like flies and rats, being able to dispose of it quickly has an added public health benefit. And the combination of food and pathological waste provides a well-balanced feed for the bacteria, keeping them stable and operating efficiently. A well-built biodigester can last for over 20 years, and they're economical to operate and maintain. And local knowledge is always a plus. If digesters are based on designs that the local builders are familiar with, they'll be able to construct and maintain them far more efficiently. Overall, in a nutshell, biodigestion is a safe and economical way to dispose of pathological and other organic waste and helps reduce the carbon footprint of disposing of healthcare waste.
Hello everyone, this study is joined with Tom Pierce from University Hospital Southampton, Tim Taylor from University of Exeter, and Kerry Morrissey from Technical University of Denmark. The project is funded by the Innovate UK and partnered with Tech Medical, who has developed a technology to recycle and reuse anesthetic gases. For the context, the NHS is responsible for 5.4% of the UK's total carbon emissions, while the wasted anesthetic gases and inhalers represent 5% of total NHS carbon emissions. Knowledge of the high global warming potential of desflurane has changed the recent practice in favor of sevoflurane. However, to the best of our knowledge, there is no study has looked into the effectiveness of such change, mainly due to lack of data and the complexity of both manufacturing and clinical settings. In response, we collected data on anesthetic usage across the UK and provided evidence based on life cycle assessment analysis. We modeled 2 different manufacturing pathways and analyzed various scenarios. We find that total intravenous anesthesia, such as propofol, remains as the most environmentally friendly drug, while desflurane has the largest environmental impact in the UK. Although its carbon footprint started to fall, by 2018, as trusts began to replace desflurane with sevoflurane. However, if sevoflurane is manufactured by a technology where tetrafluoroethylene, i.e. TFE, is used as an input agent, the overall carbon footprint of sevoflurane is as large as desflurane in the UK in 2018. Bear in mind that these findings are generated based on the assumptions that all anesthetic gases are used in an oxygen-air mixture with the lowest gas flow rate. So the environmental impact of these gases will increase if different clinical settings are used, such as including nitric oxide or increasing the gas flow rate. We also estimated the potential of vapor capture technology to reduce the carbon footprint of gases in different scenarios. One notable finding is that in the presence of a vapor capture technology with a 70% recycling rate, sevoflurane that is manufactured without using TFE could become as less carbon intensive as propofol, while keeping in mind that propofol can in addition cause other downstream harms to our environment because it is toxic to aquatic organisms. So to wrap up, manufacturing processes play a significant role in determining the carbon footprint of anesthetic gases. The differences are particularly substantial for sevoflurane. In order to minimize the negative environmental impacts of anesthetic gases, healthcare providers are encouraged to work closely with their suppliers to develop a circular model, practice sustainable clinical setups, and make use of vapor capture technologies if possible. Thank you.
Thanks again for letting me take the time to talk about our program here at Boston Medical Center. We have a program that we're very proud of called Nourishing Our Community. We started this 20 years ago with the first of its kind therapeutic food pantry. And the way that started was to address food insecurity that we were seeing with our, in this case, pediatric patients. So one of our pediatricians went to senior leadership, said we have to do more for these patients. And we did. We started off on a smaller scale with a smaller pantry that at the time was budgeted to see 50 to 100 patients. And that's blossomed into a full-blown program where we are now seeing close to 6,000 people per month. And the way that works is, they go to their provider, they refer to the pantry, almost like a food pharmacy. We use over 1 million pounds of food per year in this pantry. During COVID, when a lot of our patients couldn't come to the program, we actually did a grant and bought some vans to deliver to them. And then came our teaching kitchen shortly after, which, we wanted to teach our patients how to cook with the foods they're picking up in the pantry. So, we created a larger teaching kitchen in our larger cafeteria space, very visible to the community. They would come in, we'd have training on cardiac diets, diabetic. If you were here for bariatric surgery, we'd have a class on that. We had another class that we are very proud of, BU Medical Schools, nestled in the middle of our campus. And we had a program called Eat to Treat, which is teaching, new residents on the power of food. Food is medicine. So Olivia Weinstein, who was our dietitian, did a great job putting that program together. And then most recently in 2016, we came up with the idea is, wouldn't it be great to grow our own food and utilize it in our pantry where, we have thousands of people coming in per month. At the time, I figured, it would take 5 to 10 years to get this going. And actually 1 year later, we had 2,400 milk crates with soil, with irrigation, growing 25 different crops. So that still continues to this day. We harvest about 5,000 pounds per year. We use it in a teaching kitchen, pantry, cafeterias, on the patient tray. And we're really showing that food is medicine. We're trying to, innovate and excite people in the community to do their own growing. So we also do videos on our website. We have it's called Fridays on the Farm, where our farm manager, Annabelle, does a really nice job telling our story and really telling people how easy it is to grow food.
Great, thank you. And I'll ask our panelists to come back onto the stage again. They're just 3 of what we hope will be hundreds of practical case studies of how individuals, teams, health organizations are actually tackling the issues in climate change as well. So please do encourage your organizations to contribute to those. So we're into round 2. We've got about 20 minutes left. I'm going to take some more questions from the floor. So maybe I'll ask this gentleman at the front first of all. Thank you.
Hi. So thank you to all panelists and the moderator for joining us. I'm with Vishaydev from Prince of Songkla University. So my question is mainly for Dr. Pablos Mendes, but I would also encourage the panelists to join in. I'm a rapporteur, and I just want to share reflections on kind of during the COVID-19 pandemic, PMAC went virtual. And I was a rapporteur during that conference as well. And I found out that I could work with the same efficiency as being here in person. I just wonder whether, I acknowledge Dr. Pablos Mendes' remark regarding the need to travel here, and hence, there's carbon emission to go with the flight. Do you think we could move PMAC to be hybrid in the future? For those who need to be here in person, then, you come here in person, but for others, such as repertoire or participants who may not need to be here in person, also have the option of joining the conference virtually. So that's the first part. The second part, I'll ask later.
Do you want to ask your second part as well, and then we can.
Yeah. Well, this one goes more specifically to Dr. Pablos Mendes. I also studied global health during my PhD, and I was based in New York State, further upstate. And I think I took around 12 transatlantic flights from the US to countries in East Africa. I went car-free in the States, but every time I took a flight, I felt like being car-free was almost pointless because there was flying back and forth, emitting who knows how much carbon dioxide during each flight. So my question is, do you think when we do global health, given the improvement in telecommunications, there are ways that we can hybrid global health work as well? Or at least limit the amount of travels we do in global health while still helping to build the capacities of our counterparts. Thank you.
Thank you. Two very big questions there. I'm not too sure we're going to be able to answer them, but let's have a go.
First of all, PMAC today is hybrid. And although, again, it's a matter of impressions as to whether that's just a tail down of COVID, but it's actually not accidental. It's an explicit, assertive decision to have a hybrid conference. And I think what we would like to convey is to make sure that becomes standard going forward. And throughout the years, PMAC has been very innovative in technologies, all kinds of gadgets and things. Not all of those succeed, but the ones that succeed stay. So maybe we can have a very focused effort to make this hybrid model of conferences like the best possible to be a role model for many, many others. But I also think that nonetheless, the in-person part is first is human nature. Right. And second, so whether it's learning, because you can also just learn everything from books in Google, right? But it's the mentorship. I've been an advocate for e-health too, and I believe artificial intelligence will bring a lot of good things and so on. But even if you don't save the life of a patient, holding the hand, having a human soul caring for your soul even as you go, is so important. When I come to conferences, and for a while I was working with the Rockefeller Foundation and with USAID, you also are learning about new talents. You begin to see new talents. And it's also, that was my sort of interest, was discovering and supporting talent. But everybody has different social rationales for the interactions, and I believe they remain very important. So I think it's okay for you to get your PhD in another country and bring that experience. And I think a bit of mindfulness might bring us a bit more efficiency in how we do things. But I think PMAC is already showing us the way. Thank you.
Thank you.
Renzo.
I just want to add, and first I want to reinforce what Ariel mentioned. I think that's also still another important consideration. I'm pretty sure that over the past 3 days, we've had really meaningful and solutions-oriented conversations that probably we would have not achieved even in a series of Zoom, webinars, right? But of course, that being said, we need to have perhaps some rules within not just PMAC, but the global health sector, and not just for the big conferences, but also for the small meetings, right? There's so many meetings in global health, whether by WHO or, major global health organizations that can actually be done virtually, right? So I think this is something we need to discuss within the broader global health community. Also, what I don't want to see is that a hybrid PMAC ends up becoming an in-person event for those who can afford and a virtual event for those who cannot afford. And I'm pretty sure, I think it was also published in the BMJ recently, this article about conferences that are exclusionary because of visas that cannot be granted or that cannot be accessed by many people in the global south. And so I think that's also an important justice and equity dimension that we need to consider as we envision the future of global health convenings.
Any other comments from the panel? And just to add, I think completely right, Renzo, this is, every session has been streamed and we've got people joining from all over the world in this. It's about equity. So people who couldn't travel here can watch it online, but we have to make sure we're not exclusionary. And I think events are in transition. This is the first year really that we're back doing conferences. BMJ run lots of conferences, 40 plus all over the world. They're changing. People don't want to go and sit in a lecture theatre and listen to somebody on a big screen. They can do that. They're used to doing that on YouTube and video these days. You can watch almost any of our speakers here speak on recordings on the internet. It's about those interactions. The value of those interactions, we're still doing very well in person, but we haven't been able to transition that to online. The conversations you have in the coffee queue at lunchtime, you don't get to be able to do that online. So there is value in those. But you're completely right. I'd hate to add up the carbon emissions for the event this week. I hope that in the future we'll end up with much more efficient travel as well. But it's a really fantastic question. Any other questions from the room? Just give me a wave or catch my eye, and we'll try and take one or two more questions if we have them. Question from the gentleman at the front.
Hi, my name is Wamek. I'm a health specialist with the World Bank, and I'm reluctant to ask this question to this panel, but given the competing interests and the resource constraints in many of the LMICs that we see and work in, what is a good way to get them to focus on the climate issue over more immediate needs? And if the panel has any suggestions on how to get this through. Thank you.
Who wants to be brave and take that one?
I really think knowledge is truly power. As I say, I'm new to looking at the topic of this panel, so I'm the odd guy out here. But I was very impressed, in fact, that when you look at the actual interventions and how majority are cost savings. And so I think it's always a good argument if you could save money while doing the right thing.
I would see it a little differently. And this is where the health lens in all policies actually come in. I don't see the issues as competing issues. But then I do see that the actions could be common and could lead to a good overall health outcome. So even if it's an energy issue, I mean, powering homes and facilities, moving away from fossil fuel is a contribution to the climate conversation and to the health conversation. So when we look at even energy stream, or we're looking at pollution in water, we are actually contributing to health. So I think for me, it would be, I don't see it as a competing issue. Sorry. It would be a different approach. It would be examining issues from a health lens.
And just to add to what you're saying, I think this is an invitation for us to prioritize and explore what might be called nexus approaches, right? Projects, programs that really address multiple issues all at once. And climate and health, and perhaps food and energy, these are areas where nexus approaches. There's another group from MIT, they call it multi-solving. Projects that multi-solve. Because I think in this day and age of scarce financial resources and complicated interconnected problems, we need to be smarter. And perhaps that is the way to go, to make the most out of the limited resources that we have.
And just to add on to this, I mean, in terms of policy or addressing issues, not just health, equity, and justice would be the three anchors that I think we need to consistently examine our interventions through those lens. And I just feel, maybe it's just a very simplistic and a very idealistic kind of a belief, but I feel that if we examine it through these three lens, we'll get it right, no matter whatever the intervention is.
Any more questions? We'll take one more question from the lady at the front, and then I'm going to ask our panelists just to prepare them for a final sort of takeaway point for the audience as well. So of all the things we've been discussing this afternoon, what is the most important thing that you want people to take away or to go away and do? But let's take one final question first of all.
Well, thank you very much for that very rich discussion we had. Well, I think most of these health sector, even policymakers, they really want to have a system where they manage their health care waste in an efficient way, like, in a climate friendly way. But then again, we need to think about affordability as well as the sustainability, because by doing something in one or two hospitals is not going to make a big difference when it comes to the health sector, because you have so many hospitals and healthcare facilities. So affordability and sustainability, I think, is a key to all these things. And shouldn't we think about low cost technologies now, especially not only about the low carbon solutions, but if you just take the wastewater, which is a huge problem back in my country as well. But because we can't afford and the technologies are so expensive. We find it very difficult. And low cost technologies, and maybe like sharing of such best practices would certainly help the low and middle income countries. Thank you very much.
Yeah, thank you. Really good question. Anybody want to take an answer at that? Sorry? We agree. We all agree. So I think that's the conclusion. I think you're completely right. You saw some of the more low-cost technologies and more cost innovations about how we tackle climate change. We know that if we want to achieve this, we can't rely on just high technology solutions. We need to find ways that engage everybody in reducing the impact of their healthcare system, the environment. And we need to look at those more frugal technologies as well. And it's one of the things we are trying to collect alongside collecting some of those high-tech e-health solutions, is thinking about frugal ways that we can, use plant-based materials, reduce the impact of healthcare and the environment as well. So fantastically good point. We've got just over 3 minutes left, and I know some people are involved in the lunchtime session after this as well. So we're going to wrap up pretty shortly after 1 o'clock. I'm going to turn to our panel to give us their final reflections, so their most important points take away. I'm going to start at that end of the line, if that's okay, Shweta. So we'll start over there, and just a very quick summary of what you think is most important for people to take away from this session today.
Just 2 main points. I think it's important to take away that never before has been the climate crisis so urgent and so important. And that urgency is something that we really need to recognize and act on. And at the same time, I think that the health sector and the health professionals are uniquely positioned to influence changes in a positive way and act on climate. So I think never before has been such a great opportunity presented before the health sector to act on and act not just within the sector, but in across sector, to show its leadership on climate action. And for me, those would be the 2 points.
Wonderful. Thank you. Renzo.
Well, I think this entire conversation that we just had is really about this, and I'll take this opportunity to introduce you to this new powerful concept called planetary health. You will surely be familiar with the concept of public health, which over the past century has undoubtedly improved the health of the world, but oftentimes at the expense of the planet. And now we are being called to, and I always tell my medical students, we need to be doctors now for not just the people, but also the planet. And one way to do that is to reduce the environmental footprint of our sector, among others. So yes, I think we have a planetary health mission that we need to fulfill moving forward. The road is not going to be easy, but I think with collaboration and by harnessing all the wisdom from different sectors and disciplines, we will succeed in creating the new health systems for the era of climate change. Thank you.
Thank you. Not a pun.
Okay. I think I think the 3 days of the PMAC we see very clearly about the symbiotic relationship between the human health and planetary health. So when we have a good health, whenever the earth have a good health. So very challenge is for the public sector, we try to operate outside our work, our formal work, to meet broader, maybe take from the environmental determinant of health and some reoriented health service to be closely to the community to try to for the climate and environment. I think very important. Thank you very much.
Thank you. Ariel.
Well, first of all, thank you, Ashley, for inviting me and moderating this discussion on healthcare without harm. I would say 3 points. 1, let us keep PMAC hybrid. 2, let's make sure we make the connection between the climate and the USC agendas going into the UN in September. And 3rd, let's keep building and sharpening the evidence. Do not assume we already know, and it's just hard-headed people who don't get it. Keep working on the evidence.
Wonderful. So I think some really good and important points to take away from today. I want to thank all our speakers and panelists for today. I want to thank you for joining this session, and thank you for all your amazing questions. My hope is when we come back together next time, that the two things you'll tell us is that you feel empowered to go back and change and improve the impact of healthcare and the environment in your organizations. And the second thing is that we hope you'll come back and say that actually your organization is a positive impact on the environment as well. But first, it's time for lunch. So thank you.